Dear friends, good evening to you all. I am Dr. Arun, consultant gastroenterologist and hepatologist, practicing myself mainly in Apollo Hospitals, Green Road, Chennai, and also in Department of Digestive Health and Diseases, Chennai. Today, I am here to discuss with you all an important case scenario to whom I came across multiple times and regarding the therapeutic challenges what you are going to face when you are going to access a patient with gastric varices. You may have gastric varix with multiple presentation. Usually, you may have gastric varix in the background of chronic liver disease. As you all know, in chronic liver disease, 10 to 30% of all the bleeders, there is high possibility for the patient to land up with gastric varices. So, among them, various classifications. How are you going to tackle the gastric varix? By therapeutic endoscopy. That's one of the most common challenges that we are facing. And that area, I would like to brush you very briefly with few case scenarios that what we are coming across. Okay. With this, I'm going to make case presentation number one. And this young female, middle-aged woman who presented to us in the background of NCPH, non-cirrhotic portal fibrosis, who presented with evidence of massive hematemesis. And this patient was apparently normal a few days before, followed by the patient had massive blood vomit. At that point of juncture, we are managing the patient with terlipressin, octreotide, Varices placement, and all those things we have been supported. And followed by, we have decided to ask us what's the reason for this patient to land up with this kind of massive bleed. And this patient had evidence of this massive bleed, which was happened almost many months before. And again, this patient has been hospitalized with similar event. And during the initial presentation, the patient doesn't have any evidence of major events like giddiness or palpitation or fatiguability or abdominal pain or fever or altered sensorium. And the past history of tuberculosis was there, and this patient had this presentation, similar bleed 10 years before, and no other major systemic comorbidities, and recurrent blood transfusion was one of the significant pointer for this patient. Personal history, not much significance. Apart from that, the patient looks to be conscious. She is pain because of huge amount of blood loss and not icteric. Hemodynamics appears to be okay to some extent, and BP remains stable. Apart from that, the CNS status remains to be good, no major cardiac as well as respiratory focus. And the complete hemogram shows evidence of anemia in the background of low platelet count, but other parameters and FT remains to be fine. Viral markers are okay, and we proceeded. This is a endoscopic finding, doesn't yield any major esophageal variants. We can able to identify a prominent GOV, which means gastroesophageal varices GOV1. So this patient presented with, and after 1 day after initial presentation, this patient been reported as to identify what's the reason, and we are doing, we been able to identify massive bleed. At that point of time, the bleed gets controlled with medications like terlipressin as well as octreotide. And when we are seeing the patient, and we can able to identify a prominent varix. So what I would like to point out is, so what do you mean by the gastroesophageal varices? I mean, there are various classifications for that. Among them, the most widely accepted classification is your Serin's classification. And GOE1, the varix, if it is going to get located in your lesser curve, predominantly along with the extension of your esophageal varices, GOE2 will be in greater curve, and IGV will be predominantly in your lesser curve in the proximal body, in the proximal stomach, apart from any varix, if it is going to happen in the distal body, and diurnum will be in IgV2. And if you're going to look into the history, most of the time the bleed, the commonest presentation will be a GV1, around 60 to 70% of the population, and IgV1, there is high possibility for the patient to land up with major bleeding episodes. As I discussed with you, 10 to 13% of the bleeders in varix will be because of your gastric varices. So there are many methods to obliterate that. Right now, our intention to demonstrate you glue, how are you going to apply? See, to place the patient, that's one of the most common therapeutic intervention for gluing for a patient cyanoacrylate. When you're going to inject into the gastric varix, you need to be very, very cautious. So what are the steps you need to follow? First, make sure that the patient hemodynamics remains stable. Number two, before starting the procedure, you need to make sure all the gadgets is ready. So we need to make 3 EST needles or glue needles supposed to be there. Either it should be 21 gauge or 23 gauge. Whatever gauge you are going to available, whatever the gauge is available in your setup, you need to make sure it's supposed to be used. And 3 needles supposed to be ready, because Even if one varix, if you're going to inject at the point of junction, if the patient is going to have a bleeding episode, you can inject with another needle. So you need to place three needles supposed to be, and make sure all the solution, you need to have either dextrose containing solution or distilled water. And before you're going to inject, what are the precautions you're supposed to take? And the most important precaution, you need to take care of the patient hemodynamics, and there is high possibility for that injection to spill over in the eyes, so you need to protect the patient with good amount of goggle. And the technical person and your assistants, the staff nurse, and especially you also, the doctors, supposed to be protected. So you need to wear a good apron, your gauze, your goggles, all those things supposed to be there to protect yourself before spilling, to avoid any sort of spilling which might affect your eyes for a longer duration. So you need to be cautious, and then you need to make sure your acetone to clean off your endoscope, and your hydrogen peroxide to some extent, and distilled water. All these solutions supposed to be kept ready in adequate amounts. And before you're going to inject a glue, you need to calculate the amount of dead space in your EST or glue needle. Ideally, it might be in range of 1 to 2 ml. So first you need to inject with the distilled water to identify the amount of dead space. So next to that, once you inject the glue, at that point of time, immediately after injection, you need to flash like a rapid push technique, what we are going to use. Immediately you need to inject around 1 to 2 ml of distilled water into that to make sure it is going to get solidified. Once you're going to apply the glue, what's going to happen? The blood is going to get clot off, the monomer is going to become a polymer, so the polymerization is going to get happen at that point of time. That's the area where your gluing technique is going to be well applied. And you're not supposed, this is the commonly used glue. What you're using is endocrine cyanoacrylate, and it will be available in 0.5. You need to be ready with at least 1 ml in the initial phase to be ready. And this is what we are going to inject to this patient after a span of time. I would like to play you this video, okay? And this patient, after first, first we need to remove all the secretions in the stomach, and now I'm going to inject this varix. So identify the prominent area. Once you're going to inject this varix, what you're supposed to do, you need to be very, very cautious when you're going to inject. So you can inject an adequate amount of first 1 ml, and followed by you need to push immediately your distilled water, and you need to give a contact period of at least around 15 seconds, and then you need to look for the solidification which is going to get happen at that point of juncture. You need to look for two signs. One is red catheter sign, and another one is catheter pull. Just withdraw this the cap slightly in. When it is going to come out, it's a red, catheter pull sign will be positive. That's a good pointer. And when you're going to withdraw the needle slightly in, what will happen if the needle is going to gush with blood? So that's called red catheter sign. That's supposed to be negative if you want to do a good presentation at that point of time. So if you are injecting the varixes successfully, the red catheter sign is supposed to be negative, and catheter pull sign is supposed to be positive. And this is what you need to take care when you're going to inject your glue. That's the most important thing. And this presentation for a patient with NCPH, that's what we have been injected. And ideally, you need to choose one side. In case if at all you want to go for another side, means you can choose a different area of glue injection for this kind of patients to prevent other complications. Some patients we have been injected even up to 8 ml in our experience, but ideally not more than 4 to 5 ml for one sitting. And next day itself, we need to obliterate the glue, obliterate the varix as and when possible. And usually the complete obliteration phase will be taking at least around 2 to 3 weeks of duration. And the serial follow-up is most important. And make sure you need to take care of the cardiac assessment. Some patient will be landing up with evidence of pulmonary embolism, other respiratory complications, and other things may be reported following glue. So you need to be very comfortable. Your mindset should be comfortable when you're planning to inject a glue to a patient. So immediately after injection, this is what I would like to say. You should not be hurried to remove the scope through the, and what you're supposed to do, just withdraw, keep it comfortable, and then keep your scissors ready. You need to cut the distal end of your EST or glue needle, and then you need to remove that by a proximal end. Okay, so you should not remove the can through the distal end, because there is high possibility for the glue to spill over into the endoscope, and that may affect your endoscope completely. So what you're supposed to do, you need to cut the distal end with your scissor, and you need to remove that with the proximal. That main mistake we are not supposed to make, because many of the time in the initial phase there is high possibility for you to create such sort of mistakes may tends to happen, which may affect your endoscope. So your scissors supposed to be ready, and immediately you need to flush the surface with acetone, your distilled water, and hydrogen peroxide and other solutions, whatever you want, you can apply, and make sure that the flow of water, all the channels are functioning, your biopsy as well as the suction, your hair, water, all those areas supposed to be functioning in an effective way. You need to confirm when you're going to do this procedure. And I would like to point out with the second place presentation now, and don't expect always if the patient is having evidence of gastric varix supposed to be only a pancreas, only a esophageal, only because of liver disease, and it may because of other problems and other pointers. So you need to look into that. So the most important thing, what is supposed to do, we need to look for any other etiological triggers. This patient who had a middle-aged woman who presented to us in the background of yellowish discoloration of eyes, along with this patient tends to be alcoholic, but she's a woman basically, and she had evidence of pancreatitis. The yellowish discoloration of eyes tends to be progressive, and she had abdominal pain, worsening, pricking pattern, along with the intensity was gets worsened by your food intake and relieved by your medications. So all this prodromal symptoms findings more in favor of pancreatitis. That's what I would like to say here. And regarding the past history, similar episodes in the past, which was happened because of pancreatic issue, laparotomy for pancreatic necrosectomy, which was done in 2017, jaundice in childhood for which she took CAM medications. And this patient doesn't seem to show any high-risk behaviors. And regarding the personal history, alcoholic, and female patient tends to be alcohol, tends to have more worsening events in the earlier phase. And examination wise, the hemodynamics, not much of major issues, and clinically, no major presentation except for icterus, and the patient is having evidence of a vertical scar was there, epigastric tenderness, which show evidence that the patient is having evidence of pancreatic issues. And in the background right now, the hemoglobin is okay, platelet count is slightly in the lower side, but LFT wise, the patient had high bilirubin, OTPT is like in the higher side, albumin is like in the lower one, amylase in the higher side. And day 1 to day 10 of assessment, your vital parameters, your creatinine remains to be fine, renal issues, and sugars in the borderline. And viral markers, USG, you can able to identify cystic collection in pancreas, and when you're going to do a Doppler of your portal venous, which shows echogenic thrombus in portal vein, echo tends to be normal. And this is what the contrast CT, which revealed a prominent collection in and around the pancreas of 6 into 2, 7 centimeters, with findings in favor of pseudocyst with minimal ascites. So in which we have done an endoscopy, we can able to identify no gastric esophageal varix, but we can able to identify a prominent IgV1. So what's the plan now? Already the patient gets opinion from SG, the vascular surgeon, and we are apparatus the patient for this one. In the initial phase, not at present during injection of varix, in the initial phase before doing that, and we had a stoppage rule for 24 hours to 48 hours before we're planning to inject any glue. Apart from that, so this patient being diagnosed with alcohol use in the background of hepatitis, in the background of pseudocyst, with evidence of partial PV thrombus. So we have been treating the patient with basic medications and support nutrition. So now our plan is to inject this IgV1. So this is how we are going to demonstrate the second presentation. See, this patient had minimal bleed in and around the varix. We can able to identify this as IgV1. There is no evidence of esophageal varix. So what is the problem now? And this patient, when we are injecting there, so we need to be slightly in the proximal area, push the we need to withdraw the scope slightly. So that's what I'm trying to make an attempt. And then once I am being in a comfortable position, now the same technique, I'm planning to inject the glue into the prominent area of fundic varix, and then we are being injecting with a good technical person or being stand is or she is also a doctor. So with them we can able to identify, we can able to control this bleed, and we are going to inject around 1 ml in this side comfortably. And after taking all the adequate precautions, after taking all the adequate measures, what I'm telling it is, So this is how, in case if you want to inject again, and see this is hard. So once it's going to produce a prominent solidification, the polymerization is going to get complete. So this is what the technique we need to follow when you're going to inject a glue. Assessing the patient, make sure all the gadgets, your equipment protection, your protection, staff protection, patient protection is most important. Take care of all those things and look for the evidence of catheter pull sign and red catheter sign. All those things you need to look into that, and before we are going to inject the patient comfortably. And whenever going to withdraw, make sure that should be done in a proper way. This is the second slide I would like to demonstrate, and this is how we need to take care of this. And your 3 ESG needles. So the take home message: identify the dead space prominently. 3 ESG needles supposed to be there, and assess the patient hemodynamics and look for any evidence of active bleeding. And you can reassure the patient once you are done the glue injection. After that, next day you can check within 124 to 48 hours. You can assess whether the patient is having another bout or anything, in which we can have another sitting within a span of 1 day. We can do another glue injection sitting, so that we can plan. And usually within 2 weeks, the glue, the varix will be obliterated. And always you need to be cautious. The contact period once you inject, it should not be around 15 seconds. Usually you need to count, and you should not go beyond that, because sometimes you'll be having difficulty to withdraw. So 15 seconds, slightly withdraw, look for red catheter as well as catheter pull side, and then you need to remove through cut. Always keep scissors ready, cut through the distal end and remove the tube to the proximal end, your ES needle through the proximal end. It will make the procedure comfortably. Flush out all, clean out the secretion, check the hemodynamics, see the patient ECG status, and rule out any major complications of pulmonary embolism when it is going to get developed. And certain questions I would like to address here. There is no role of any lipodil nowadays, which was used in the initial phase, and no need to dilute your glue at any point of time. Always you need to keep your distilled water as well as your dextrose solution. You need to be ready, and don't give more than 1 ml in one area at one point of time. You can inject in different quadrants, some of the areas, but not in the same area at 1 ml, not more than 1 ml at one point of time. And usually you need to be ready with 21 and 23 gauge needle. So that's what the predominant area should be recommended. And apart from that, if you have any further queries, I'm happy to address over here. And thanking you all for patient listening. With this, I'm resting the presentation. Thank you very much.